Excellent. Well, I've got a lot of questions here, and a lot of them sort of interestingly fall into groups. So I'm going to start with you, Patty. With reference pricing, is there any steerage that goes on to certain providers?
Absolutely. There's a lot of steerage. Nurse navigator, and that's part of the communication with employees, is that they are required to call the nurse navigator before they have a procedure to help with that steerage and to give the employees options. And what happens in this with this is that employees will call nurse navigator and they'll give them options. So they're not forced to go in one direction, they're given the options, and so employees have those choices.
What size companies typically use it?
You know, for reference-based pricing, we're seeing them down to 150 employees. HCSS that you heard earlier, that's a form of reference-based pricing, and they started out 120 employees. So.
Okay. This one is, these two are sort of related. It's really more for the other payers. How can an insurance plan justify? Actually, this is probably left over from the debate last night. How can an insurance plan justify paying 3 times to a hospital-based service when compared to private practice? This is the main reason why doctors are becoming employed, which has significantly increased healthcare costs. And the second one's sort of related. What are you doing to keep doctors independent and in private practice?
All right, I'll answer the second question first. So, again, I think keeping independence independent. I was having this conversation earlier with Diane and others. It's not even just about the physicians. It applied to surgery centers. It applied to imaging centers. Payers are part of the reason that consolidation and acquisitions have occurred over the last 10 years in the way that they have. I mean, frankly, the imaging, the freestanding organizations were the organizations that didn't have the leverage to negotiate the pricing that some of the more clinically integrated systems did. So as a result of that, when some of the larger organizations would come and say, we can purchase you at 5 times what your value is, they know that they're going to be able to make it up in the long run through the clinically integrated structure that they have, both on utilization from a standpoint of steering volume to those organizations, as well as some of it related to pricing. So it's a combination of utilization and unit price. We've got TMA Practice Edge is something that we put in place, all the pay for performance initiatives that we put in place, all the ACOs and medical homes that we put in place. The majority of the programs that we've been launching are physician-driven programs and physician-centric, because again, it goes back to recognizing the power of the physician. As it relates to hospital-based services, I'm going to interpret that as being affiliated with a clinically integrated system / being employed by a clinically integrated system, maybe not necessarily hospital-based in the way that I traditionally think of hospital-based, which are your pathologists, your radiologists, your ER physicians, your emergency room docs, and your neonatologist. I hope the question that I'm going to answer is the first part of my comment, which was, you know, when we do contracts with clinically integrated systems, we look at everything in totality. You got a combination of physician pricing, and you've also got a combination of the hospital pricing, and you look at what the overall cost of care is in total. Obviously, not going down the path and talking about, and I won't talk about directly any type of contractual arrangements, but we do take into consideration the totality of the arrangement that we have with a particular provider organization, especially clinically integrated systems.
Samantha, you want to comment?
I believe that we face a lot of the same challenges when it comes to that, but when I was referencing how we view healthcare as done at the local level, that's something that in Texas we constantly have to go back and remind our counterparts in Hartford and the folks that make the initiatives and come up with the numbers of the 75% should go through value-based. We have relationships with many of the large organizations out there that are equipped to do these value-based programs that we have outside of the small ones that we have as options for independent physicians. It's not our goal to force everyone to go into a larger relationship, but we have to manage the patient's care. It all comes back to that. So I think that's one of the reasons that Aetna is focused as well on helping members to recognize healthcare as something that has to be done proactively versus reactively. They have to get engaged. When we look at all of our costs, Rick's right. We look at the total cost of care, the episode of care, and all of that, and that is easier to do whenever you have a full view of the spectrum. But we also of the patient care. But we also do that in a similar fashion when it comes to providers that or members that are considered to be unattributed, which means they are not part of a home, patient-centered medical home or an ACO, something of that sort. So we are constantly working on that. It's just a matter of having all of the other benefits that are in place to get that momentum and keep that synergy going, so that we can let the patient care be at the center of what we're doing.
Patty, do y'all?
Yeah, I mean, I think obviously talking about any type of rate structure, I think, is inappropriate today, frankly. I mean, it's an environment where we've got a lot of different constituents that are represented here within the provider space, and I would prefer and will not answer direct questions related, especially when you're talking about percentages of CMS.
Okay. Patty, do y'all have any difference between your reference price for an independent physician or one that's employed?
Now, on the reference-based pricing, the independent physicians are on the PHCS network, so it is a richer benefit for the doctors that are involved with the PHCS network than it would be for Blue Cross Blue Shield. But there is no, on the facility as far as the hospital, because we're negotiating Medicare plus a profit margin, typically it takes all that away.
Okay. Well, I've got a question here on bundled pricing, so I'm going to bundle it with a couple of other questions. What are you doing bundled pricing for, heart or ortho? And what metric are you using for surgical specialties and pay for performance? And how do you establish and validate clinical metrics for your value-based performance measurements? I think those are all sort of in the measurement family.
So I'll just talk a little bit about what Aetna is doing with the bundle pricing. We haven't, like I said, focusing on the hips and knees. We do have a what could be considered a bundled payment relationship. It's proactive. It's been in place for many years, but that's not one that we as an organization, that's in cardio, and it's here local. We do not have that being rolled out to other entities right now, just because of some of the complexities within our system and the relationships with the multiple physicians. But for the hips and the knees, where the bundles, we find them complementary to the population health management models. They emphasize the primary care, and they're going to reward the better care, and they have the criteria. It says that, I'm sorry because I have not done one of these yet, so I'm reading from my notes. That their goal is to improve the standardization of hospital and specialty care for these procedures and kind of fill in the gaps that might remain. I know that we are doing that. We are looking at it in other specialties as well, but we're not far enough advanced in the bundle pricing for the hips and the knees at this point.
The only response I'd give it, Blue Cross is, I think the jury's out on bundled pricing, frankly. Outside of the complexity associated with bundled pricing that Samantha talked about, bundled pricing is somewhat of an enigma because there's a lot of system-related issues with bundled pricing, as well as trying to determine what all is included in the bundle. So in other words, let's just say you got a cardiac bundle. If you've got 10-day the actual surgery, and then you go 30-day post the surgery for that bundled pricing, and you've got a lot of independent providers that are part of that, one, you've got to have an organization that's going to gather all of the claims. We've got to, on our side, be able to administer all of those disparate claims coming in from different providers to ensure that we're not going to pay for them. Plus, if you've got included in that bundle, let's just say you've got rehab, you've got physical therapy, so rehab, let's say it's a SNF or somewhere else, you've got the facility costs, you've got the professional costs, you've got lab services, professional being the surgeon, the pathologist, the radiologist, imaging centers if it's done pre-bundle. It makes it very, very complex to be able to administer a bundled payment under a scenario where you have so many disparate providers that are part of that bundled payment. And even though if you don't start reducing some of the utilization associated with some of those unnecessary services, so as an example, imaging, but it's included in the bundle, then you may not be making headway as part of that bundled pricing. At some point, you've got to get some unit cost reductions as well in order to make the pricing be competitive as it relates to what the expectations are of a customer when you do a bundled agreement. So it's utilization plus a unit cost reduction.
Okay. This one's actually for the moderator. Where did you get that ugly necktie? It's amazing what you can find at the dollar store. We have 5 minutes to go, so I'm going to conclude with one hard question I think is also left over from the debate last night. A lot of focus has been on provider accountability for value-based healthcare. What steps are being taken for insurance company accountability with rising premiums at the same time lower provider reimbursements are being paid?
So my first response to that is not only are our customers asking for change, they're demanding change. And by that, I mean, I talked about earlier, what keeps percolating to the top is payment reform. I think what you're seeing from a payer perspective, and specific, I can talk about Blue Cross, is an investment in technology and being able to try to work with the provider community in such a way where data is extremely important. Historically, the way that the two organizations have worked together, meaning the provider community and the payer community, is there wasn't really an exchange of data. And I think what we've seen over time is that both the payers and the providers are starting to collaborate under these value-based care structures, which frankly I think is what our customers are demanding in order so that we all are trying to achieve the end objective, which is to end up trying to mitigate the trend that's currently occurring today. So the investments in technology, the actual bidirectional data exchanges that are occurring, in particular in some of these population health models, are going to, hopefully in the long run, they're not all going to be successful. We're not going to sit here and say that we've got the panacea that's going to resolve everything, but you got to start somewhere. And I think through the willingness to let go of some of the data that has historically been very critical to a payer from a confidentiality perspective is a step in the right direction in trying to enable providers to be successful. They are the ones that are navigating the healthcare system on behalf of the members. We are also a contributor to that, but I think we would all agree that the majority of the time, the member listens to their doctor. They listen to their trusted physician, and so it's imperative that we work with the providers, not against the providers.
Samantha?
I would tend to agree with a lot of what he just said, but we also have, as far as I talked about kind of at the upper end of the spectrum, the JV relationships with the provider entities. We have one in Texas that is on its way out the door, so we're really excited. We've learned a lot through implementing that, and we'll see where it goes, but also in the discussions with the plan sponsors when we get them into the review of the different products that they're interested in or what they want to offer to their membership. We touched on it earlier. If you want to have a better price point, then you may have to sacrifice some accessibility to providers. And I think that a lot of our plan sponsors have been willing to do that and support that as long as we can help them deliver that message to their members. We have several large employer groups here in Houston that have done it over the past couple of years and actually really helped us pave the way as far as getting these contracts in. But they in turn expect to see those changes in their premiums and see where those savings are. As far as how much of those actually get passed down to the member, of course, there's a lot of dynamics that are in between there, but we are sharing information with the providers, with the plan sponsors, so that everyone is able to kind of look, have the whole scope of information to look at and make decisions about.
Patty, you get the last word.
Well, with reference-based pricing, it takes a lot of that out of the way because it's pretty clear what the plan pays. It's very transparent, and that's what, being the middleman. USI is insurance consultants, and that's, the company I work for. We're the middleman between employers and the providers and the insurance companies. And we're just getting, it's becoming imperative that we find ways to mitigate the healthcare cost. And so this is one of the ways that we're helping our clients do so, and to be more transparent. That's all we hear is employees want to understand what it costs for them to go in and get a knee surgery, what it costs to go in and have a baby. I mean, you have grocery stores where there's 3 different kinds of milk, and based upon different ideas, they're wanting to look at medicine in the same way and in the same manner. And so that's what this particular program is trying to offer employees and employers.
Well, we had more good questions than we had time to cover, so I think our panelists will be around for after the session to answer any questions one-on-one. We can arrange a smoke-filled room to negotiate individual contracts, and I think that you should give this panel a hand for handling a very difficult session.